All right, so Adam, is there anything else you had mentioned that she should have been counseled differently regarding the C-section? But other than that, was there anything else that could have been done that would have changed the outcome, that would have made the difference?
I think similar to after looking at the prognosis for semilobar holoprosencephaly, I think that talking to a neonatologist in the antepartum course could have been helpful. I know it was difficult. It's difficult to make a diagnosis like this, especially if all of the genetic testing has come back without any definitive results. But talking to a neonatologist about fetal outcomes could be important if the patient wanted an abortion, because these are pretty dire outcomes for a baby.
Adam, did you have a consult with pediatric neurology?
And not that I saw in the notes. But she must have. She must have if she had the MRI.
So Adam, like we never consulted.
Hey, Morgan.
Hey, Adam.
Hey, sorry, I was just saying that she did have that consult, but it was like 4 days before her presentation to L&D, so it was like almost term pregnancy by the time she had that consult.
Hey, Adam, just to add one thing is that we never consult neonatology for this type of problem. They're not the right group. We will consult them about other things, of course. But this is a consultation that once we've made the diagnosis, MFMs tend to do that counseling if we can pick up something. Once we do the MRI results, we do that research and figure out what to need. And then just like Dr. Kempinski asked, we certainly do involve the pediatric subspecialists or the surgical subspecialists to talk about potential outcomes. But it's almost a never thing to counsel about the anomaly with the neonatologist. We don't do that.
The pediatric neurologist was involved prior to 26 weeks when there was a decision point about whether or not she would keep the pregnancy or not.
Thank you very much.
All right, well, Adam, thank you very much. Excellent job as always. So it looks like we have a minute or two of a break before we get ready to gear up for grand round. So thank you. All right, well, it's about 8 o'clock, so we might as well get started. In just a minute, I'm going to ask Dr. Bayat to introduce our Grand Round speaker. But in the meantime, just a word or two about attendance. We'll be taking attendance using the participants list of the WebEx at 8:10. If your name is listed clearly, you'll get full credit. If your name is not listed clearly or there's more than one person sitting at a computer, feel free to email your attendance to me or Michelle or Beth. And with that, Dr. Bayat, are you ready to introduce our speaker?
I am. Good morning, everybody. I have the distinct privilege of introducing Dr. Zhang this morning, who's joining us from the Department of Neurology to talk about a topic that is always near and dear to us contraceptive prescribers, which was migraines with and without aura. Dr. Zhang completed his medical education at George Washington, his residency in neurology at Mount Sinai, and then subsequently a headache fellowship at NYU. He then joined the Rutgers Robert Wood Johnson family as an assistant professor in the neurology department in 2018. He's published 15 articles with 3 more on the way, and seems to have a niche interest in the incredibly fascinating topic of using artificial intelligence in headache medicine. And as if that clinical care isn't enough, he's also been heavily involved in software development pertinent to the evaluation and management of headaches. Dr. Zhang, it's our privilege to welcome you to our OBGYN Grand Rounds. And as someone who has referred a few too many patients to you to help me figure out if they have migraines with aura, I'm truly excited to learn from you. Thank you so much.
So much for inviting me. Actually, it's a wonderful pleasure to be able to talk to you guys about migraine with aura, without aura. I think that I'm hoping that this talk here is more like a discussion, really, about what I guess OB/GYN does, and also what we neurologists think of as migraine with and without aura, and how to manage the contraceptives. I think that we definitely need to have more discussion, and this hopefully is the beginning of one. So anyway, so my name is Phil Zhang, and assistant professor here in neurology. So I guess I'll start if see if I can get my slides going by first telling you my disclosures. So I don't really have that much disclosures. All right. So okay, so maybe the first way to begin the setting is to describe headache as a subfield. So essentially, headache as a field, the way that I look at it, at least academic headache, is one that's bounded by a lot of rules and guidelines. So a good first example would be how we diagnose headache in general. And this is usually done through, at least in academic headache centers, by an agreed upon document that we call the International Classification of Headache Disorders. This is actually how we diagnose migraine. So I'll show you the migraine definition. So this is the migraine without aura definition according to the international criteria. I will board you by reading it to you. So the criteria, there's essentially 5 criteria, A, B, C, D, and E, and you have to satisfy all of them. Criteria A is that you have at least 5 attacks of whatever headache that you want to diagnose as migraine. Criteria B is that these headaches have to be 4 to 72 hours. And criteria C, you have to have pick 2 of the following 4. So the 4 things are either unilateral, pulsating quality, moderate to severe pain, aggravation caused by avoidance of routine physical activity. And then criteria D is you have to have at least one of the following, which is nausea, vomiting, or photophobia and phonophobia. And something that I consider probably, and actually most headache specialists probably consider the most important criteria in any of these guidelines is guideline E, or criteria E, not better accounted for by another ICH-3 diagnosis. So you cannot be something else, essentially. All right. So the definition of migraine with aura is also here in this handbook of ours. And it also has criteria. So it's also 4 criteria this time. And criteria A is you have to have at least 2 of them. Criteria B is that you actually have to have reversibility, fully reversible symptoms of specific kind of neurological symptom. Okay, so these are specifically visual, sensory, speech or language, motor, brainstem, and retinal. So retinal migraine, by the way, is essentially just a monocular version of the visual migraine, which is defined as binocular. So visual field is visual, and retinal is just one eye. Okay, so then you also have to kind of qualify these each aura that you think is aura. And you have to at least satisfy 3 of the 6 criteria here. And I'll bore you again by reading it to you. So the first one would be like gradual spreading symptoms for more than 5 minutes. Number 2 would be at least if you have 2 auras, they have to happen in succession. 3 is that individual aura symptom lasts 5 to 60 minutes. At least 1 aura has to be unilateral, at least 1 has to be positive, and maybe a headache afterwards. So again, criteria D is the one that we all care about, at least headache specialists, not better accounted for by another ICH3 diagnosis. So one more slide. We also actually in this guideline actually have a definition for what is considered chronic migraine. And I will not actually bore you by telling you about the specific nitty-gritty of this. But essentially what's happening in the chronic migraine diagnosis is that, well, aside from the not better accounted for by another ICT3 at the very bottom, what you can diagnose somebody with chronic migraine if they have more than 15 days a month of migraine headache, or if they have 8 days a month of migraine headache, but other days are being like tension type headache features or so on and so forth. So essentially chronic migraine is just a worse version of migraine. All right, so okay, fine. So in some sense, I kind of did my job by telling you what migraine with and without aura is, and I guess the grand round can stop here, but I won't, of course, right? So because this is grand rounds. So anyway, so maybe the best way to go forward from here is to kind of think to ourselves, why should we accept this guideline? How are they made, and what is its limitations? So, I mean, in some sense, this guideline is kind of a circular logic, but kind of not. So initially what happened was this. Initially what happened is that this idea of trying to classify disease, at least in headache, didn't really start until maybe the 1920s or the 1930s. And prior to that, as everybody knows, like migraine has been with us ever since, beginning of mankind, right? So we all have a sense of what migraine is, even in the 19th centuries, of what we think of as migraine and what we think of as like, other kind of headache. We just never really put the words to it. So in 1982, the International Headache Society, which is essentially the governing body internationally, or not maybe a governing body, but at least a consortium of headache specialists, come together and say that, hey, we kind of want to study this disease, headache in general, and we need a guideline. And so what they did is they got a whole bunch of people together in 1982, and they came up with the first edition of the international criteria. So in some sense, you can think of this guideline being generated by tradition. People taking ideas from their mentors way back in the 1800s or 1900s or whatever, and then the idea of what migraine is comes down to us by tradition. The second way to look at this guideline is that because this guideline is made by a committee, they are essentially expert opinion. So, for example, this neurology article here, Classification of Primary Headache Disorder in 2004, these people who are writing this article are all essentially on this committee. And remember, headache is a rather young field. It started in like the 1980s. And even at that time, there weren't that many headache specialists. So these people tend to be people who are, who train other headache specialists and are expert opinion. And so what happened is that after these guidelines are published, usually just like the other kind of guideline, there is a whole series of people publishing articles and trying to figure out whether there's an epidemiological kind of justification for these things. Sometimes they don't think so, sometimes they do, and then eventually they publish another edition. So I don't have the first editions print here, but this is the second editions. What that look like? So, and to be sure, I mean, I'm sure you realize this by now. If you look at the guideline itself that we just read, it looks very much like DSM, and that is actually like the psychiatry diagnostic statistic manual. And actually, it was significantly influenced by that at that time when they actually generated these things. So, if you guys are interested in this, literally yesterday, Yes Olson from Danish Headache Center published, he was there in the first edition. So he like kind of published a retrospective or perspective on how these things are made. So in some sense, like, yes, these things are, this guideline is actually maybe what we think of as a circular logic, right? So you first come up with a guideline, and then you study the thing, and then you come back and you try to adjust the guideline. But I mean, I think there's really no way of avoiding it in headache. And perhaps it's best to quote maybe the philosopher Heidegger in saying that it's probably best not to avoid a circular logic, but to enter into it correctly. Anyways, so long and short of it, we have this guideline that's kind of created by all these factors. So once you have a guideline, we always think about things. It's like, well, are there loopholes in this guideline, right? I mean, is there intentional loopholes that people have built into this guideline? And are there also loopholes that are unintentional? So there is a very famous intentional loophole in this guideline, and everybody knows it's been put in there intentionally. And that is that if you look at the guideline for migraine with aura, you will soon realize that migraine with aura does not necessarily include headache, which is a strange thing to think about if you aren't used to thinking about this stuff, because when we think of migraine, we think of headache. And this is actually intentionally put in because there is actually a subcategorization of migraine with aura. It's called typical aura without headache. And this is the criteria. I'll read this to you because it's very simple. The attack's fulfilling the criteria for migraine with aura, but does not have a headache. So the reason this is put in this way is because to account for a thing in neurology called acephalgic migraine, which is now the new term for this typical aura without headache. And essentially, this is what it is. It's entirely possible for people simply to have the aura phenomenon of the migraine without having the headache. So I'm also gonna, because it's Migraine Rounds, I guess I will plug my own article shamelessly in where I kind of exhaustively listed a possibility of even diagnosing 2 headaches at the same time according to this criteria. So yeah, so there are loopholes in this criteria. It's not perfect, and some of the loopholes are meant to be there. Other ones are maybe not. Anyways, okay, so that's enough theory. It's great. That is what we think migraine is, but we don't live in the universal. We live in the particular, right? So like my favorite philosopher Kierkegaard was saying, the central point of being human is that the unit 1 is the highest and 1,000 counts for less. So I guess with that said, let's look at some cases. Okay, so these cases are essentially they're real life cases. I almost never pick ones that I made up because I think they're kind of lame. But let's look at the first case. All right, so case 1. All right, so case 1 is a 55-year-old male, past medical history of Hep C, hypertension, 40-pack year of smoking, asthma. And essentially what happened is he just came to the ED with some mild numbness involving the 2 digits of his left hand, the left corner of his mouth, and the left side of his tongue. So this started suddenly and without anything before it. Lasted approximately 6 hours. And before he came to the ED, he got a little scared. He came in. And it's been there ever since he arrived at the ED. So he doesn't have anything else really. He doesn't have any like illness, trauma. He doesn't even have a headache. No confusion, mental impairment. Pretty much nothing. So then, you examine this guy, and he has a blood pressure of 104/69, not that bad. An EKG, that's normal sinus. And this neural exam is pretty much completely normal, except that when you touch his hand in the left first 2 digits, it's like a little bit more sensitive. So it's a positive symptom, I suppose, to pretty much all modality, like temperature, light touch, that kind of thing. And then when you touch the corner of his mouth, upper and lower lips, and left side of his tongue, you also have some of the same thing. So we're all neurologists. Well, the neurologist here, or the ED physician here actually, was like, well, let's get a CT head just to make sure. So they got a CT head. It's all normal. Okay, right. Okay, so what do you guys think this is, right? So let's try out this criteria. Let's try out the migraine with aura criteria because this guy doesn't even have a headache, so we're probably talking about migraine with aura, right? If we are to talk about migraine. So criteria A, okay, so this is his first attack. Criteria A required 2 attacks. But you always think to yourself, well, before you have 2 attacks, you must have 1 attack. So maybe this is his first one, right? So it's not that bad. Okay, so that's not like that suspicious. So criteria B is like, okay, fully reversible aura symptoms. So in this case, it would be a sensory aura because he would have these changes in sensory in his hands and things like that. Not really fully reversible yet, but I suppose aura. Anyway, so criteria C. Let's see how many he satisfied here. So he has 1 aura symptom spreading that essentially occur suddenly. It's a little bit hard to tell, right? Because he had a sudden onset symptom. Now, when people say sudden, do they really mean 5 minutes, or they just mean like right then and there? So maybe criteria. He doesn't have 2 auras, so criteria C2 is not there. C3, okay, so symptom lasting 5 to 60 minutes. So his is a little longer. It's like for 6 hours. So maybe not that one either. But certainly 1 aura symptom is unilateral. It is on his left hand, in his left face. Okay, so yes, criteria C4. At least 1 aura symptom is positive. He definitely has a positive symptom here. When you prick him on his fingers, he can feel it. I mean, it's even more than normal, right? And he does not have this this headache that comes with it. And we did a CT scan, so maybe criteria D, right? Okay, so I guess by the way, this kind of sensory change in headache that involved the finger and also the mouth had a specific name. And this is an article by Tepper from Headache. The Headache Toolbox is a thing that MHS put out every now and then to summarize headaches for people, mostly for patients. And the sensory changes are the second most frequent form of typical aura. And when you have this finger mouth thing, we usually call it the chiral oral aura. Okay, so how many of you did I convince that this is migraine with aura? So okay, so actually, this is not migraine with aura. This is actually a thalamic infarct. And again, I did not actually see this patient because I took it directly out from this case report. So the interesting thing here, actually, what happened was that they actually saw this guy at the emergency room, and they thought his symptoms were so mild, they were going to discharge him. And then they were debating whether they should discharge him. And then finally somebody was like, well, we have neurology, so why don't we consult neurology? So they consulted neurology and they got an MRI, and that's how they found out that this is a thalamic infarct. Okay, so case 2. So case 2 is definitely something that you are going to see maybe once in your life. Okay, so this is a 50-year-old woman, no past medical history, who came in with 4 episodes of headache. This headache, 4 episodes of headache, sudden onset in the back, severe headaches. The headache is associated with vomiting. She said that when she lifts things up, when she strained a little bit, her headache gets worse. It affects the back of her head, maybe spread both sides into the temple from the back, and lasts approximately 2 hours on each whenever she has the headache. The episode only happened like once every several days apart. She took some Tylenol. She didn't get any better, but did not have anything else really. Okay, wasn't taking drugs either. Okay, all right. So physio exam. So essentially a normal physio exam for maybe a little bit high blood pressure, 160 over 90s. No neck stiffness, nothing. So the ED guy got a normal white count, SED rate, CRP. Just like the last case, did a CT scan of the brain. After seeing the last case, we got a little bit smarter, so we decided to get a lumbar puncture. That didn't show anything really. And then we're like, well, we're not there for the last case, right? So we got MRI of the brain, also unremarkable. Okay, all right. So how does this work with migraine without aura, according to the international criteria? So let's see. So first of all, okay, so you have 5 attacks. You're supposed to have 5 attacks fulfilling, all these other qualifications. So she has 4. So I guess same logic. If you have 5, you must first have 4. So I suppose maybe. The attacks are a little shorter than 4 to 72 hours. But, you can make the justification that, sometimes even in pediatric headache, you can have 2 hours headache. So, not too surprising, really. The headache has at least 2 of the following 4 characteristics. Let's see. So unilateral location. So that's not true. She has bilateral, right? Pulsating quality, not entirely sure. Maybe. But she certainly has number 3, which is moderate to severe pain intensity. And whenever she lifts things up, it makes it worse, right? So maybe number 4. She definitely satisfied the nausea criteria, nausea and vomiting criteria for criteria D. And you already got her an MRI. So maybe, we can say yes to criteria E, right? So if you were truly to use ICHD3 because of the first criteria not being satisfied, you would probably call this probable migraine without aura. Okay? So if you catch the drift, you'll finally realize this is probably not migraine because the last case was migraine. So therefore, why would I give you a second migraine? Right. So this one actually is what's called idiopathic RCVS. So the only reason we know that, and this is a case that I took it directly from this case report, the only reason that people know that is because they did an MR angiogram. And they noticed the specific beating pattern on the MR angiogram right here. So I don't know, do these 2 cases surprise you? Maybe our criteria doesn't work, or maybe you really, really have to satisfy the specific things in the criteria, like exactly for us to diagnose migraine. I mean, are those things really true, So I guess the lesson here, the reason I want to bring these up, these cases up, is that in some sense, in the realm of headache, you cannot really just look at the criteria. You kind of have to look at where the criteria lives. And this is where the criteria lives in. So the criteria, this is the payload content for the international the ICHD3. You'll notice that the parts of the ICH3 are divided up into the primary headache disorder and the secondary headache disorders. So migraine, which is a primary headache disorder, only lives on one of the many, many ones in here. In fact, 1 out of 12. So everything else is something else, right? So essentially, that is the caveat here, is that you really kind of have to think about other things in order to diagnose migraine. You cannot just base it on solely what that condition is in the actual criteria itself. Okay, so if this is like kind of scary to you, or maybe not scary to you, I don't know, but if this is kind of disconcerting to you, there is a easy trick that headache neurologists generated in order to avoid this kind of stuff. And that trick is called the SNOOP criteria for checking out red flags. So that's why, and this is an article by one of my collaborators who essentially listed the SNOOP criteria. So SNOOP criteria is this specific thing, which are a list of red flags that should hint to you that a headache is not a migraine or some kind of primary headache disorder. And I lifted the slide directly from the slide we give to medical students. And it's not to insult people, but rather to say that we think this thing is so important, we give it to all of our medical students so that they know that they really learn this. So what does SNOOP criteria stands for? So the systemic symptoms are things like fever, malignancy, immunocompromise, and pregnancy. So pregnancy specifically, actually the standard of care for pregnancy in headache, in patients with headache who has, in patients who are pregnant who has a new onset of headache in pregnancy, is actually to obtain MRIs, MRI brain, MRI angiogram, and also an MRI venogram without contrast to essentially rule out a host of secondary headaches. So obviously, if you have any neurological deficit, such as papilledema, focal neurological deficits, impairment of alertness, then you also hint to you something else is going on. If you have some new onset of headache that is different than normal, you will also think to yourself, maybe something else is going on. And if the person is just really old, maybe not really old, I mean like 50 is the cutoff, I guess that's not really old, then you would also kind of think to yourself, should we image them? And if there's any pattern change or provocation by position of Valsalva, you would then image them or think about something else. If you look at this criteria, and you think back to the case I present to you, actually they have a lot of these things going on there. So, for example, the first case certainly has a change in headache phenotype or change in a new symptom. They also have a new focal neurological deficit. And the second case, the migraine, the quote-unquote migraine without aura case, has with it a age greater than 50, the provocation by Valsalva, because remember when she bent down and picked things up, it makes her headache worse. And also like the fact that her headache, actually, I think that might, let's see. Yeah, I think that's pretty much it for that. But her headache is new compared to her normal, because she usually doesn't get headaches. So this criteria is actually pretty good in figuring things out. So we can even go one step further and say to ourselves, fine, we have these criteria. But really, you can think of the SNOOP criteria or the SNOOP guideline as another way of restating the imaging guideline from the American Headache Society on when to image for migraine. So this article published in 2019 is essentially the guideline by the society to, in some sense, combat radiological imaging being denied for people with migraine. Anyway, so they asked a whole bunch of experts, they went through it and then trying to figure out what is the evidence-based guideline, what is not. So here's the surprising thing, or maybe semi-surprising thing, is that grade 8 evidence, so strong recommendation, high quality evidence, is that if you really think somebody has headache that is consistent with migraine, like 100% normal neurological exam, then no red flags, then you actually do not need to image them. But on the other hand, grade C evidence, which is actually low quality evidence, but strong recommendation, is that you will image people who you think have migraine, but with some specific features. So those features are listed here. They're like unusual, prolonged, or persistent aura, increasing frequency, change or severity of the migraine, first or worst migraine, migraine with brainstem aura, confusional migraine, hemiplegic migraine, late life migrainous accompaniment. So that's like, people get migraine more than age 50. Migraine aura without headache, SILAC migraine, and post-traumatic migraine. So we look at this these kind of lists here. Case 1 and case 2 also fits nicely as reason for people to image. And by the way, when a headache neurologist says to image someone, we usually do all three, which is the MRI of the brain, MRA, and MRV. Okay, so what's my point? So my point in showing you all these slides, all these cases, is really to tell you that, or to bias you, how about this, that you should be a little bit suspicious of obvious answers, and the obvious answer being migraine. Because the things are, these things are subtle sometimes, and if you are only assuming that you're seeing migraine, you will only ever diagnose migraine. Okay, so we're going to switch gears to see how we treat migraines. So just like a diagnosis has guidelines, there is also essentially a rule following how people treat headaches in academic centers, and this is the big paradigm of using both abortive medication and prevention medication concurrently to treat headaches. So in general, there are three classes, if you can think of it that way, of medications to treat migraine. There are the abortive medication, which are there for people to take when they have a headache, to stop the headache. And then there are the prevention medication to prevent that people would do daily to prevent the headache. I mean, it doesn't have to be a medication. It could be a strategy also. There's also this third class of medication or use of medication called the bridging therapy, which we won't talk about. Is essentially it's a transition therapy to break a bad cycle of migraine. Okay, so the guideline, so every couple of years, the American Headache Society comes together with all their famous people and essentially trying to figure out a consensus on what is accurate and what medication they like, what medications they do not like for abortive and prevention treatment based on evidence. And that's usually the pretty nice go-to for trying to classify the abortive and prevention medications. So this slide is the abortive medication slide. And this is all pretty much all the big class of medication that's used for stopping a headache when you have one. So there's some migraine specific ones, as you can tell from here, which are triptans, ergotamines, gepants, which is a newer class medication, the CGRP antagonist, and then lasmiditan, which is essentially a triptan mimic. So there's also non-specific ones such as NSAID. There's also the combinational analgesic like Excedrin, that's right here, and IV medication like magnesium, antiemetics, those kind of medications to stop headaches, but they're probable efficacious. And this is the society's guideline on what medication are effective for prevention of migraine. So remember, prevention medication usually take 3 months to kick in. So these medications are meant to take on a long-term basis. So they are things such as blood pressure medication like candesartan, beta blockers, and anti-seizure medication like Depakote, valproic acid, and the novel class of anti-CGRP medication, the epanizumab, all these kind of injections. And of course, there is Botox. Probably effective are antidepressant as well, and also memantine, the Alzheimer's disease drug, and maybe combining the the CGRP antagonist with the Botox. Okay, so I think when I got this invitation that the reason that you invited me to talk is because we want to talk about migraine in pregnancy, and also migraine contraceptive use in headache, and that comes later. So anyway, so here's the thing. The thing about what to do for patients in pregnancy is actually kind of controversial, even for headache neurologists. So you have a wide different array of opinion in terms of where people are trained and in terms of how aggressive people think they should be. And then also combined into that is essentially some kind of legal landscape that people are trying to avoid. I'm sure that is an issue that's not lost in this audience. So, I mean, some people, for example, would say that triptans are okay. For example, like sumatriptan, they have not really noticed any side effect when you're using it during pregnancy. So some people would do that. And other people would use things like Botox even, and thinking that the justification is that the molecule for Botox when they inject it does not really, is too big to cross the placenta. So before I go ahead with these slides, I think it's probably best for me to just tell you my own bias. And my own bias is really shaped by my mentor when I was trained in headaches. And essentially it is that we don't use anything for headache when people have when people are pregnant. And I would love to hear what, during the Q&A component, what your thinking is about this topic. So anyways, I always thought you don't know what the annotation thing is, but I will say okay. Strange. 1 second, I think there's an annotation request here, and somehow that prevented me from advancing the slide. That works. Okay, there we go. Okay. All right. So, but I think that, this being Grand Rounds, I am semi-obligated to tell you about the standard of care. So I think the easiest way to go about this is not to ask me what I think you should give to people who are pregnant, but ask the American Headache Society people what they would like to give to people when they're pregnant. So this is an interesting study that I thought that I find interesting. So this is a study by Catherine Hamilton, who's now at Georgetown. Essentially what she did is in 2020, she went about the American Headache Society listserv, and she asked everybody to fill out a survey, and whoever that's like a headache neurology certified to fill out a survey on what they feel comfortable giving pregnant women, both in abortive medication and prevention medication. And so she got a response from 196 people. Now remember, in 2020, there were only really 500 UCNS certified headache neurologists. So this is essentially almost, I guess, 2/5 of them. Okay, and this is what comes back. So on the top, you have a chart that says who is comfortable with abortive medication, what kind of abortive medication is people are comfortable with. On the bottom, you have what kind of medication people are comfortable using as prevention. Okay, so the abortive medications. Okay, so let's look at this chart a little bit more detail. So the color actually matters here. So there are these different medications, and if the color is light, so this white thing, that means that they're very comfortable using it. And then if it's dark, it says they're not comfortable using it. And this is that percentage of people who responded to saying how comfortable they are. So, for example, the top 3 that people are most comfortable using, and this is all headache specialists, okay, are essentially Tylenol, non-pharmacological techniques, and nerve blocks. Okay, and the thing that people are not comfortable using are things like butalbital, opiates, and also muscle relaxers. Okay. So those are the abortive ones. So for the prevention ones, people are very comfortable using the non-pharmacological stuff, nerve blocks, as well as neuromodulation devices. And people are very, very not comfortable using things like Depakote or Topamax, which makes perfect sense why you would be comfortable using that. Or the novel class of medication, the CGRP monoclonal antibody, to prevent people's headache during pregnancy. Okay. So in case you don't know what these things are, when we say, I'll just quickly go over them. When we say neuromodulation device, what we're really talking about is these kind of devices that you put on your body and essentially zap you or modulate your brain when you have a headache. So the most popular one is the Cephally device, which you put on your head. It's essentially a TENS unit. And the other one that is newer is a armband called the Nerivio device. This, by the way, I have no industrial affiliation with these people. Okay, who are there that you would zap yourself essentially once every other day for prevention, and you can also zap yourself one time to stop the headache when you have one. You can do the same thing with Cephally device. Okay, and when we say non-pharmacological technique, what we're really talking about is actually these kind of cognitive behavioral feedback kind of thing, or behavioral medicine way of treating headache. So there's actually quite a lot of evidence behind using relaxation technique, which is this app here. Not necessarily this app, but this is one of the most well-researched ones, to kind of relax when you have a headache for prevention. And usually I tell my patient who are lesser well off that if they don't have the money to do that, they can always try to seek out Dr. Dawn Buse's website. So Dawn Buse is a very well published researcher in behavioral medicine. And she has on her website some resources on how to relax and things like that. And then finally, when we talk about nerve blocks, what we're really talking about is essentially mixing up some lidocaine, steroids, or maybe some other kind of long-acting versions of lidocaine, and injecting it into people's occipital nerve to break their headache cycle. So as you can imagine, because all these things are topical, they should not at least mess with the fetus. Okay, so I'm actually really curious to hear about your approach during the Q&A session about what you would do for people who are pregnant. I guess maybe the best way is for me to tell you a little bit about my approach for it. And as I've told you before, my bias in my training is that I really do not use much medication to treat people's headache when they're pregnant. And I think because of and I'm not saying that that I am entirely correct in doing that, but my justification is that usually the thing that we do know about headache in pregnancy is that every trimester the frequency of headache and the quality of headache and the way headache presents actually changes a little bit, for migraine anyways. And so remember, the prevention medication usually takes 3 months to kick in. So the advice that I was always told in training is that even if I were to put somebody on a medication, let's say during first trimester, and then their headache become way better during second trimester, I'm certainly going to attribute it to my work. But in reality, is that really the case? So, but anyways, so that's my bias. And strangely, I find that, in my practice, if you talk to people before they're pregnant, or even in early, I guess, time in their pregnancy about these things, they're actually really receptive to it. And I never really have a situation where people are well counseled in terms of my approach to pregnancy, headache in pregnancy, and then come back and be really upset. Okay, so all right, so one last controversial topic, and I just realized I'm probably running a little late here, but this will probably be quick. Is the one that Dr. Bayat has mentioned before, is aura and contraceptive. So I guess the question really is this: what should we do about estrogen, essentially, or combinational hormonal therapy in patients who have migraine with aura? And for those who don't know, the reason we worry about this is because there is a known increased risk for people to get ischemic stroke if they have a diagnosis of migraine. So whether it's with or without aura. And specifically, the thing that is worrisome for people is that for migraine with aura, there is an increased risk for stroke. So even more than migraine without aura. So the biggest question here is, if we, as we all know, if we give people a lot of estrogen, they're also going to increase the risk for stroke. So what should we do for these people? So I picked a specific article, mostly not because I love this article, although Techen is a very nice lady. I picked this article because this is actually our article that we had to read this past year for 2023 in order to recertify our headache boards. So if you want to think of it that way, this article essentially summarizes what the American Headache Society and also what the guideline is for migraine headache specialists in treating for contraceptive in people with migraine with aura. So this is actually the summary slide from this article, and I will summarize it for you. Okay, so I'll go through every single one of them, but I won't read it to you. I'll just summarize for you. The first one is this. The first one is that pretty non-controversial, that people who have migraine with aura should stop smoking and live better lifestyle. Okay, right, great. Everybody should do that, whether you have migraine or not. Second one is that if you notice somebody has dyslipidemia, you should treat it. If you have noticed somebody has like endothelial activation or dysfunction for whatever reason, you can maybe think about using blood pressure pill, that kind of thing. Okay, fine, whatever. So the third point here is that a woman with active migraine with aura should not be started on combinational or hormonal contraceptive. Okay. Number 4 is that progesterone and non-hormonal ways of contraceptive are completely okay. At least they are okay with it. Okay. For migraine with aura. And then number 5 is that if you start people on combinational hormonal contraceptive, you should probably give them some kind of antiplatelet. At least you think about giving them antiplatelet. And 6, 7, 8, you probably don't care about. Number 6 is we don't really know anything about PFO, and then like should we close it or not? And we shouldn't really give triptan to people. I'm sorry, you should not have people take triptan during the aura phase. And then we don't know anything about the CGRP antagonist in terms of like how it affects the migraine with aura. So functionally, what the slide is telling you is essentially summarizing the advice that has always been around in the headache community and in my own training throughout the years. And that idea is that if you have migraine with aura, we usually advise patients to avoid migraine estrogen in general. Everything else, that should be fine. So so Dr. Ebert actually sent me this article and say like, hey, actually, there is this other article here that's in 2017 that talk about combination of hormonal contraceptive and migraine. So this article essentially provides maybe a contrapoint to the one we had before. And the critique of essentially restricting estrogen in migraine, maybe I can summarize it for you from this article, is that the reason we believe that empirically that estrogen can cause more stroke in people with migraine with aura is the fact that a lot of these studies were done with older data with higher doses of estrogen in people's oral contraceptive. And because we're using less high amount of estrogen in recent oral contraceptives, maybe that does not pose an increased risk of stroke in people with migraine with aura. So yeah, so I think the funny thing about this in reading these two articles is that people's bias actually do kind of come into the interpretation of the data. So for example, they have both cited a specific Danish study on essentially contraceptive and low dose contraceptive, low dose estrogen contraceptive, and how that increased the rate of does that increase the rate of stroke. And the funny thing here is that the article before from Tichin actually used that study to justify the fact that low dose of estrogen is nevertheless still increasing stroke risk. Whereas this current article here is using that same study to justify that it does not. So I'll let the nitty-gritty, I mean, you can read the article to read the nitty-gritty. But maybe we can talk more about that during our our Q&A session. But here is my go back here. But here's my own way of thinking about this. My own way of thinking about this topic is that it really comes back down to that quote from Kierkegaard. Essentially, we don't really live in a society. We don't really live in the universal. You know, we live in a particular case basis. When you see a patient in the clinic, look, if they have no reason not to be on the progesterone, they have migraine with aura, they have no reason not to be on progesterone only contraceptive, then sure, why not, right? I mean, why are we doing that? Why are we giving somebody estrogen, right? But there are plenty of cases that you do need it. For example, people who have prior, like, you know, they have plenty of reason to do it. And I guess in every single case, you just simply have to go through it in a case-by-case basis, telling the patient what the theoretical and empirical risk and benefits are. And I think I'm out of time, and that is my slide.
All right, Dr. Zhang, thank you so much for this excellent talk. Are there any questions? Dr. Bayat?
Hi, good morning. Thank you so much. That was so helpful. I was hoping it would allow me to refer less people to you, but I'm still not sure if that's going to happen, so my apologies in advance. I have kind of two questions. I think the first thing is how you navigate the patient who can't really give you a great history about her migraines or headaches. I feel like I encounter this all the time where I'm trying to establish, do they have an aura with their migraine or do they not? And the patient's like, maybe this happened, or they can tell me something that sounds like a very typical aura, but it happened just once, or they're not sure. And I feel like that's really where I struggle, because I don't want to withhold, you know, I don't want to put her at risk of unintended pregnancy, but at the same time, I don't feel confident enough in my, you know, headache analysis or assessment to say that, okay, it's fine for her. And that's usually when I end up sending them to you. So I think that's my first question. And then the second question is, does the migraine, like, do migraine headaches change over time? So if I see a young patient who's 25 who has migraines without aura and she's been using combined pills, do I ever have to periodically reassess her migraine history to see if she now has aura? Or can I say that if you fall into one category, you're always just going to stay in that category? Thank you.
Yeah, thank you. So Yeah, so I think so maybe the first question. So it is the struggle to determine whether somebody has migraine aura actually doesn't get completely gone. Even I realize even after I did my headache training, it just become less and less fearful, so to speak. So a lot of times you won't be able to determine. But the good way to think about this is that, especially in the case that you're actually practicing, you do have a guideline to kind of help you. So the reason that the so yes, if you're unsure, you can refer them to me or a neurologist to think at the second eye looking at it, because a lot of these things are kind of subtle and kind of like a little weird, you know. The guideline does help you though. If you look at the guideline does tell you that your aura has to be specific kind of things. So, and they are intentionally doing it that way so that you won't ascribe everything in neurology to like the migraine aura when you can't find something. You know, for example, visual auras, or like, you know, like the visual sensory hemiplegia, retinal brainstem, those kind of things. So, for example, if people come in with some kind of brain fog, if they're not having language deficit, that doesn't really qualify as an aura per se, you know, according to that criteria. And the other thing also is the duration of the aura, and those you know those things about pick 3 out of 6 things, you know, like 5 to 60 minutes, all that kind of stuff, right? So remember, people probably can have aura that is like maybe 4 minutes, but not 5 minutes. But on the other hand, the good thing about the ICHG3 is that the guideline is used both for research purposes and also for clinical, I guess, diagnostics. So you can think of it this way, that the people that they realize that has increased risk for migraine, for stroke in aura, are actually people who probably have like 5 to 60 minutes of aura. You know what I mean? Not like the people who have like 1 second. So sure, we can, like, people can debate on individual basis whether somebody who has 1 second of flashing light is that an aura or not. But those people are, I mean, they can go either way. You know what I mean? You can make the justification saying that, hey, that is too short to be an aura. It is not an aura. Or you can say, well, it probably is an aura. But either way, it wouldn't be the people that they're really studying when they're studying risk factor for stroke. So I don't know if that kind of make you feel a little bit better or not. I mean, it's hard. You know, aura is not necessarily something that we can be, hey, this is what it is, this is not. But the guideline can sometimes help you, or actually help you a lot of times. And the second question is, do migraine changes when patient gets older, or changes? They do. So there is a so Richard Lipton in Montefiore in New York had this longitudinal study on how frequent people's headache changes, that kind of thing. And we noticed that people's migraine frequency actually fluctuate a lot in their lifetime. And even if we don't have that study, you can still kind of think of it in the sense that most people start getting, well, not most people, the highest time for somebody to become intractable in their headache is roughly in their late 20s and early 30s or maybe 40s. So these people are often, as teenagers, having headache that are episodic migraine, and then they transform, so to speak, into chronic migraine thing. So yes, so they do change. And so that question that you asked about migraine with aura is a well question. It's like when somebody doesn't have an aura before, eventually they have aura. You know what happens? Well, yes, I think you should kind of warn them that if they start getting aura, they should let you know and maybe change your aura contraceptive. I think the easiest way to do this, and you know, you might have better ideas on this, is actually to tell them on the first visit. So, like, I mean, essentially, when they tell you, you know, I do have migraine in the first visit, then you tell them, hey, oh, do you have aura? They say like, no, okay. But then you ask them, and you tell them, well, when you do have an aura, let me know. You know, so that way, like, you do kind of somehow have to revisit it. You kind of have to think about it, but it's also kind of maybe tell them about it as well. Yeah, I hope that answers your question.
No, it did. Thank you. That was very helpful. And I just have one follow-up question, and then I'm gonna stop hijacking the forum. The question I have is, if someone's migraines with aura are well managed and under control so that they're not having migraines, does that mitigate their risk of ischemic stroke? Like, can I use that as a gauge as to whether or not estrogen-based methods or combined hormonal methods are safer for her because she's not having headaches since they're so well managed?
Yeah. So in essentially the short answer is that we don't know. The reason for that is that I think there's a couple of detail here. The big thing is that is the aura. So first of all, if you look at the recommendation from the Titchen's, so the strictest criteria, right, from Titchen's study, right? She actually the wording is that it's active migraine with aura. So I guess that tells you what her bias is. The other thing is we should think about though is like why are they having the aura? And so a lot of people don't have an aura. I mean, they have an aura because they just have an aura, and it's like they have like maybe aura twice in their life. And you're like, well, um, and like maybe it's just part of the migraine process. But other people have aura because they actually have an underlying like hematological problem. So I guess the thing is, I mean, I don't think people essentially put this into words, but essentially, if your aura is more weird, you're probably more worried that it's kind of be some kind of underlying hematological pro-inflammatory weird process that's going on that's vascularly related. So you're less inclined to take that risk. Whereas people's aura is like more standard, so to speak, like a visual aura that is like 5 minutes, then you're also less scared. I know it's not a straight answer, but yeah. So there's simply no like it's debatable on how that would go.
I see that Dr. Phillips has her hand up.
Hi, thanks for this talk. Migraine is always kind of one of our biggest fears, I believe. I could ask you 14 questions, but I'm going to start with one. Migraines are not, they're all or none. So many patients say, I used to have an aura when I was younger, but I don't have it now. That's one question. The second question is menstrual migraines with aura. And then the third question is, what are the brainstem aura symptoms?
Um, I, I guess the first question is migraine all or none, right? In some sense, yes, it is all or none, because the like if you want to go by the international criteria, once you're touched by migraine, you do have migraine for the rest of your life. Now, to be fair, do you care about this migraine that happened one time in your life or not? I mean, that's just like the last question is kind of debatable, and also clinically debatable, I guess, relevance, right? The second question, I think you're talking about menstrual-related migraine. Can you clarify your question specifically about menstrual-related migraine? Yes.
There are some women who only get migraines right before their period and they go away after their period. And even though it's unusual, occasionally I see somebody who has just a menstrual migraine, but also has a little bit of an aura with it. Usually the best treatment for that from our point of view is estrogen, but again, is that a different class, or is that an aura is an aura is an aura?
Yeah, it's more like an aura is an aura is an aura. But the thing is, like, I mean, to cut to the chase, but the way to think about that is that menstrual-related migraine is treated actually a little bit different than all the other migraines, in the sense in episodic migraine patients. Okay, so if you're like somebody who gets headache every single day and their migraine is worse during pregnancy, I mean during menses, that's a different kind of approach. But if you only have somebody who only gets maybe 4 days a month of menstrual-related migraine, in those patients there is actually a specific way of preventing it, which is called the mini prevention. I think that if you simply just look up mini prevention menstrual-related migraine, it will come up. Essentially, you kind of give people something around the time of their period to kind of block that. Using estrogen to treat menstrual-related migraine is actually an older kind of way, not to say that it's not effective, to say that it became in vogue in the era where we don't have much targeted therapy for migraine, and that's and then somehow it's not a wrong thing to do. It's just somehow it kind of fall out of favor, and I'm not sure why. But I do think that you probably should avoid the estrogen component if you have a very straightforward case of migraine with aura during the menstrual period, because there are other ways of doing it, essentially.
All right, well, we only have 60 seconds left, Dr. Levine, if you can squeeze your question in.
Okay, here we go. Anyway, thank you again for that presentation. As a family physician, we certainly see a lot of patients with headaches and especially migraine. But I get a lot of patients who come in who would benefit from estrogen-containing contraception for cycle control, acne, and other reasons. And many times we find out they don't really have migraine with aura, they have photophobia. But my understanding is from the International Headache Society is their updated guidelines do say when a patient only has visual aura, that those patients can use low dose combined oral contraceptives. I just wanted to clarify that with you because that is something that I found in my research and have been now applying to those patients. And I just want to make sure I'm not misunderstanding these updated recommendations. Again, using 20 milligrams or lower can be used based on what it's stated in the International Headache Society. So thank you.
Actually didn't come across that, so I would love to see that.
Sure.
Yeah. I mean, if you go by Tetchen's, our CM, my board review article there, then I guess the answer would be no. But on the other hand, I don't think you should be, like, I mean, listen, I mean, I was thinking about this yesterday. I was like, I actually went to look it up. I'm like, how often do people get in a car accident? Like, how likely am I gonna die tomorrow just because I drove here, right? That's like 1 in 101 to 107 apparently. So I have 1% chance of dying, like literally driving here. And all of you guys are assumed drove here. The likelihood of even at the worst case scenario, according to the older study of people getting a stroke from migraine with aura, taking estrogen is like 5.9 in 10,000, I think 100,000. So that risk is very low, and that's what that article, the second article, has been suggesting. So I think the thing is, if in medicine, there's always risk. If you tell them, look, there's a theoretical risk of this, I don't think that you need to be militaristic or whatever you want to call it, authoritarian maybe, to say like, hey, absolutely no. But they just have to know that there is that. But I would love to see that guideline because I think the IHS actually does not put out practice guide. Well, no, that's not true. They sent out a recent practice guideline for people to review before they publish it. But yeah, I would love to see that.
Yeah, I'll forward you the article. But yeah, because we've applied that with several patients and who would, like I said, clearly benefit. And either we're misdiagnosed, especially those who just have photophobia, or have simple visual migraines. And I think my colleagues would agree, we very often use 20 microgram containing combined oral contraceptives and very well. And these patients really benefit. And so compared to ones who have more TIA-like, symptoms. But thank you again.
All right, we are out of time. So I just wanted Dr. Zhang to thank you again for this excellent talk.
For inviting me.
And everyone, I hope you have a safe and productive day. Thank you.